Hi, welcome to Cardiology Case Series. This is Dr. Keshav, Director, Fortis Cunningham Road. We welcome you all to this Cardiology Case Series discussion. In this program, we are going to present to you interesting case discussions about cardiology cases. What is important is I am going to make it simpler for physicians. We are looking at physicians treating a cardiology case and trying to interpret what are all the signs and what are all the symptoms, what are all the ECG, echo findings and all. It is not a hi-fi interventional cardiology what we are discussing. We are discussing a simple case of a heart attack or a myocardial infarction and day-to-day management of arrhythmia, how to interpret these things. That is what we are going to discuss. Today we welcome you to the first case. This first case is a 55-year-old male. He is from Arsikere. He is a non-diabetic and a non-smoker. He is hypertensive 5 years and he is taking amlodipine and is well under control. He had an inferior MI 8 years back, for which we had done an angioplasty to him 8 years back. Post angioplasty, after 1 year, he had a massive GA bleed because of the aspirin, and he was at present only on clopidogrel. And religiously he was following up, and he had undergone a treadmill test every year and it was negative, and he was exercising regularly, and his BP was well under control. He was not diabetic and he was doing quite well, and he was on only clopidogrel because of the history of GI bleed, which was a proven gastric ulcer. So he was on only clopidogrel and statin, and he was doing quite well. He had 4 months back, he had a sudden onset of chest pain at 10 p.m. and went to a nearest hospital. He was in Arsikere, which is around 200 kilometers from Bangalore, and he was told to have a second heart attack. And this is a small secondary care center, small nursing home. A physician immediately diagnosed that he had an interval MI, and he immediately thrombolized with ritaplase, and within half an hour his chest pain subsided and he was stable, and he was shifted to us after 12 hours. So this is a case of a hypertensive who had an old inferior MI, successfully underwent stenting, and he was doing quite well, and suffered an interval MI. Now from the history, what you can gather is this is a second heart attack. So you have to take this as a significant risk factor. So what are the MIs which are high risk from the history itself? From the history itself, you should note that anybody who has got a interval MI is a high risk patient, because interval MI carries a higher mortality. Now the second thing is anybody with a past history of MI, like this patient who had an old inferior MI, now he is having an interval MI, is a high risk patient. Anybody who has undergone an angioplasty is a high risk patient. That means that he had one stent is already, one vessel is already diseased, now the second vessel is getting diseased. Third thing is anybody who has undergone a bypass surgery is a high risk patient. So the important issues are interval MI is high risk, past history of MI is a high risk, past history of angioplasty is a high risk, and past history of bypass surgery is high risk. And what is the pulse rate and BP? If the person pulse is very high, tachycardia or bradycardia is a high risk, and the patient having a arrhythmia is a high risk. So this patient, another important clue what we get in the history is this patient has undergone heart attack, inferior MI 8 years back, and he has underwent regular TMT every year. It was normal. So what does it say is, the most likely the stent in the right side or right coronary artery is normal, because whenever we put a stent, the renarrowing chance of the stent is between 6 to 9 months. So after 9 months, most likely 99% the chance of stent getting blocked is very low, and this person had a treadmill test negative. So that gives me a clue that that stent was okay from the history itself. So these are all the clues what I could gather from the history. So the history, and they will all give a very good information for me that this guy had undergone a stent, most likely the stent is okay, now his second vessel is getting blocked, and he has undergone a thrombolysis, chest pain disappeared within half an hour after thrombolysis. All these things says that the vessel involved is LAD, and possibly the vessel is open because of the thrombolysis, which is the best thing anybody can do. And obviously the physician has done a good job by thrombolizing him, putting him on aspirin, putting him on a clopidogrel, and putting him on statin, and shifting within 12 hours. So the important thing is, after a thrombolysis, the best time to do angiogram is between as early as possible, 3 to 24 hours is better to do the angiogram. So, this person, when he came to me, he was hemodynamically stable, pulse rate was 75, BP is 120/80, saturation is normal, he had no chest pain, no breathing problem, he was comfortable. So, as such, when he came, we did the ECG. So, if you see the ECG at this thing, you can see that he has a good, you can see that there is a QS complex from V1 to V4, there is a good ST resolution. So, there are two things will say that the vessel is open. One is how is the chest pain. If chest pain is fully resolved, it is says that the vessel is open. Another thing is we have discussed in our ECG course that the ST segment has resolved very well and the Q wave has formed, which will also tell that there is a good ST resolution, which says that the vessel may be possibly open and there is no tachycardia, there is no arrhythmia. All these things says that the vessel may be open. That says that the thrombolysis has definitely worked in this patient. And we did an echocardiogram. It showed a hypokinetic apex, apical IVS, apical anterolateral wall, and anti-IVS, and EF is 45%. So, what does the echo tell? Echo, the important information I would like to say, hypokinetic means mild damage, akinetic means moderate to severe damage, dyskinetic means severe, grossly damaged, irreversible damage. This person has a hypokinetic hereditary, and troponin is very high. This says that the vessel is open immediately, so the troponin goes up sky high, which is also a sign of reperfusion. The sky high troponin within 12 hours suggests that the vessel was occluded and has opened up. Now, after this, since it is a high risk patient, second MI, previous angioplasty and interval MI, he underwent a angiogram. So, he underwent a elective angiogram because he is a high risk candidate. So, in the angiogram, as I show you, here you can see that there is a ulcerated lesion in the proximal LAD with a briskly flowing vessel. You can see that hazy looking lesion in the LAD, proximal LAD, and in the other view it looks like borderline, but in this view it looks like a significant lesion. So, since it was a recently thrombolized patient, we do expect a good amount of thrombus in this type of vessels, and you can see that the thrombolysis has worked, though the residual lesion is around 70 to 80%, and immediately underwent a drug-eluting stent, and you can see now that the result is quite good with a brisk flow. But the important thing is, if you see that this flow into the septal artery, which has become slightly slow, and the RCA, right coronary artery, you remember that he had a stent which is also quite good. Now, if you see later that this patient has got a sluggish flow in the LAD when we are checking after this thing, and this is the angiogram which shows that patient had a lesion which is seen in the brisk, it took for a comparison. You can see that the lesion in the proximal LAD and the final result in the this thing. Now, after this the patient was stable and he was shifted to CCU. Now, in the CCU, this is the ECG. If you see that the STs have slightly gone up post procedure, heart rate is quite good, he was comfortable. So, the ECG says that evolved interval MI at a slight post procedure STs have slightly gone up because of this sluggish flow in the this thing. So, it looked like a straightforward case. Then a series of events started happening. So, we will then the next day morning again you see that the STs are slightly up, but the patient was comfortable. ECG showing evolved interval MI. But within 24 hours, he suddenly started complaining of palpitation. Suddenly, we see that he has developed a atrial fibrillation. So, atrial fibrillation following ischemic heart disease or acute MI happens in 5% of the patient. Here, the ECG, I want you to concentrate that the irregular heart rate with a QS complex in V1 to V3 and a V4, and STs which are resolving, suggesting old interval MI. But I would like also to concentrate for you that the patient has developed a right bundle branch block. and the axis which has become a left axis now. Right bundle branch block with the left axis, that suggests a bifascicular block. Now this ECG within 24 hours has moved from a walled anterval MI to right bundle branch block and a left axis deviation suggesting left anti-AMI block. So that's a bifascicular block. So the same patient who was stable has started. Why this all happened? Because the LAD flow following stenting was slightly sluggish flow, and that is the reason he started developing a bifascicular block. So then the patient heart rate stabilized without much, we didn't start him on cortisone or anything, heart rate stabilized, atrial fibrillation was there. So we added injection enoxaparin, he was on aspirin and ticagrelor, statin, and ejection fraction was 45, so he was an AC inhibitor and carvedilol. So with this he was stable, but before we didn't shift him within 24 hours to ward, which is the usual protocol after angioplasty. We said we will observe him for one more day because of atrial fibrillation and RBVB and left axis. So the important thing in myocardial infarction is anterval MI has a mortality rate of 7 to 8%, but once you develop a bundle branch block, the mortality rate doubles, 15%. Once you develop a bifascicular block, mortality rate again goes up to 18 to 20%. So it's important to observe the ECG, what are all the changes happening. Why these changes happen, we will discuss. So anterval MI, mortality around 8%, but if you have a bundle branch block, anterval MI with RBVB or LBVB, it doubles. Once you add a bifascicular block, it goes up further. So the important thing is we have to watch for this on the series of ECG whenever patient complains of changes. So by next morning he was comfortable. So here again you see that patient is in sinus rhythm, he has a right bundle branch block, ST is settled, and he has got a axis deviation which is almost, this is left axis deviation. So RBB with a bifascicular block, anterval MI, ST is settled. So we said because of these changes we will not shift him to ward, but if you see the STs have significantly regress. So that means that the flow to the distal vessel is quite brisk. Now again we observed him, again we repeated ECG after 6 hours, which again shows that the right bundle branch block is persisting and the left axis is persisting. So this is a RBV, but STs have almost resolving back to normal. So the TIMI flow, the flow to the vessel is okay, but the bundle branch blocks had less blood supply because of the slow flow in the left anterior descending artery. So this was an important clue for us not to shift him back to the ward. These are all the important signs, how to take these signs, and suddenly you shift the patient to ward, he becomes breathless, again shift him back. These are all not good signs that okay, these are all things saying that he may develop into more problem. So RBVB with left axis deviation or right axis deviation is called a bifascicular block. RBVB with left axis is called RBVB with LHB. RBVB with right axis deviation is called a bifascicular block involving posterior AMI block. So this person had anterval MI which has resolved now, whereas RBVB with left axis deviation suggesting a bifascicular block. Now then ECG started showing some more changes. We took him for a check angiogram which showed that the LAD was briskly flowing. Now suddenly at morning 5 o'clock we got a call that suddenly his heart rate was 50. Then we took another ECG. Here you can see that he has got a RBVB, he has got a right axis deviation, and he has got a complete heart block. So the P wave you can see here, P waves are not P wave and QRS are not synchronized. There is a dissociation between P and QRS saying a complete heart block. So this is a clue that this person is gone for initially for a anterval MI, then developed a right bundle branch block, then the left posterior AMI block, then they developed a complete heart block. So that was a very good thing that we didn't shift him to the ward, we had kept him in ICU, kept on monitoring this patient, because RBVB, anybody who develops MI with RBVB, chance of developing complete heart block is high. Anybody with a MI with a bifascicular block developing what you call a trifascicular block, that is RBVB, LAHB with prolonged conduction in the posterior AMI block, posterior fascicle will give rise to complete heart block. So the next day morning he developed a complete heart block. That is when we had put in a temporary pacing, we observed him for 24 hours, which took a check angiogram which showed a brisk flow saying that this is going to recover. So the next day morning he had reverted back to sinus rhythm. his STs have completely regressed. Watch that his RBVB has disappeared, watch it, his axis has become normal. So within one day, within 2 to 3 days, he has developed a RBVB, then he developed a bifascicular block, then he developed a complete heart block, and again regress back. So ischemia is the only thing where these type of things can keep evolving every day, because ischemia regresses over a period with medication. We have opened the vessel, the flow to the first septal artery is brisk, so that it became completely normalized. So with this, I would like to show you the applied anatomy of what we have discussed. Here you can see that there is a SA node, this is the AV node, there are 3 bundles which connect the SA node to AV node, and this is the bundle of his. Bundle of his after that divides into right and left bundle. Left bundle has anterior and posterior fascicle, right is a bundle which supplies the right side. Now the blood supply to the AV node and the bundle, that's what is the important thing in this. So AV node is supplied by the right coronary artery, that is the AV nodal branch which comes from here, and this is the one which supplies the AV node and bundle of his. Right bundle and the left 2 bundles are supplied by the first septal artery. That's why this person had anterowall MI, he had a lesion here, so which was supplying the right bundle and the left anterior bundle. So these 2 were affected because we had a slow flow here, he had a bifascicular block. After that, because even then the posterior fascicle was also acted, so that he develops a complete heart block. So there is an important difference between an anterowall MI complete heart block and an inferior wall MI complete heart block. What is the difference is, if you see this diagram, in right coronary artery, even if the small branch gets affected, entire AV node gets affected. A small lesion can cause a complete heart block. So the damage is less, but the AV node recovers very fastly. So inferior MI with complete heart block has a better prognosis. Why? Because the amount of damage is less. Now look at anterowall MI with complete heart block. The RBVB is affected, right bundle is affected, anterior fascicle, posterior fascicle, so huge area is affected. So anterowall MI with complete heart block carries a worse prognosis compared to inferior MI with complete heart block, because inferior MI has a very tiny area which can damage the AV node, whereas the anterowall MI has to damage the right anterior fascicle left, posterior fascicle left, so it causes a huge damage, causing a complete heart block. So this is the important thing. What I would like to highlight is anterowall MI with complete heart block has a worse prognosis because of a huge damage, and it is usually RBVB, LAHB and LPHB, so trifascicular block. Whereas inferior MI is a complete heart block due to AV node disease, which is small damage, so that recovery will be faster. So inferior MI with complete heart block has a better prognosis, and it will be narrow QRS because the damage in the AV node, infra-Hisian areas are okay. Whereas in anterowall MI complete heart block, the damage is quite extensive, patient will have a significant LV dysfunction, and it is a trifascicular block, so and it will be manifested by a wide QRS compared to inferior MI, we will have a narrow QRS. So this is another diagrammatic representation. SA node is supplied by the right coronary artery, and AV node is supplied by the small AV nodal branches coming from the right one, which is a red artery depicted in the red, whereas the LAD, which supplies the anterior fascicle, right bundle, left anterior fascicle, left posterior fascicle, and the right bundle. So it will have a huger damage to cause a complete heart block. So now after this, the patient was stable, he was shifted to ward, and his ejection fraction remained at 45%. He is stable at 4 months. He was put on aspirin and clopidogrel for 1 month. After 1 month, we had kept him back on only clopidogrel because of history of GI bleed, and he is an AC inhibitor, beta blockers and statins. He has completed 4 months of follow-up. He is doing extremely well, and he is walking 3 to 4 kilometers and doing well. So in summary, what is the highlight of this case is, what are the high risk characteristics you can find, and the history. Anybody with a history of 2 MIs, that's the past history of MI, anybody with a past history of angioplasty, past history of bypass surgery, and anybody with the anterowall MI, these are all from the history itself, you can say that they are not a good signs. Another important thing is, what is the pulse rate? If the pulse rate is less than 50, more than 120 is a bad sign. Then BP less than 100 is a bad sign. patient having breathlessness, crepitations, and the examination is a bad sign. Now another important clue is, suppose somebody has thrombolized the patient, whether the chest pain has disappeared and ECG has shown a good improvement, which is shown in this case. This is an important clue to say that the vessel is open. Now another important thing is, sometimes you can have a very good angioplasty result, but the patient, because of the slightly slow flow, you can have arrhythmia. In this case, I have shown you the patient coming with a good ST resolution with the following this. He has developed first RBBB, and again he developed a LAHP, then he developed a complete heart block. Since the vessel was open, we did a check angio, vessel was open, and all the things reversed. So ischemia is the commonest cause for reversible bradyarrhythmias. Suppose you have ischemia, bradyarrhythmia is there, you open the vessel, bradyarrhythmia regresses. In the same patient, he had a RBBB to start with, bivesicular block next, and he had a trivesicular block, complete heart block. Again within 24 hours, everything regressed. Patient was managed with the temporary pacing for 24 hours, and he did quite well. So the management of this patient, I would like to do a treadmill test at the end of 6 months to see his whether the stent is patent. So treadmill test is fine, he doesn't have chest pain and exercise, I will say that stent is also doing well. Whenever we put a stent, we say wait up to 6 to 9 months, do a treadmill test. If possible, if the LV function is good, it will tell us that okay, the stent is patent at the end of 6 to 9 months. Is a good non-invasive modality to convince the patient that okay, you can, and it will also tell us how much exercise he can undergo, is also a good test to tell us. So this patient is doing well. Thank you. Next week, in the next session, we are going to come out with another simple case of a myocardial infarction or arrhythmia, and how does the patient come to us, and how does the patient. These are all case series to help the physician to know how to pick up the clue on the ECG, how to manage this patient, how to convince, talking to the family and explaining. So this will tell us how to manage this patient. We'll come with another good, interesting, simple case for the family physician or somebody who is managing a intensive care to manage this patient and follow up.